मेरा नाम डॉक्टर साजिद मजीद है मैं कंसल्टेंट चाइल्ड स्पेशलिस्ट हूँ टुडे वी विल डिस्कस an important short case of ataxia. Your command will be patient having difficulty in walking, do gait examination or do gait and relevant examination. Whenever examiner give command of gait, think about following diagnoses: cerebellar ataxia, Friedreich ataxia, space occupying lesion, and low down ataxia telangiectasia. As ataxia telangiectasia, the patient are sick, early age disease, less than 2 years, chest involvement is serious, so less likely to be in cases, but you must keep in your mind of ataxia telangiectasia. Now first introduce yourself and take informed consent. जैसे मेरा नाम डॉक्टर साजिद है, मैं आपके बच्चे का मुआयना करूँगा जिससे इसकी बीमारी की तशख़ीस में बेहतर मदद मिलेगी. Warm hand if cold weather is outside. Make a good exposure from mid chest to mid thigh. Now do observation for 20 seconds. As the examiner has given clue of gait in command, you should think of ataxia. So do observation with the same reference like look for nystagmus. If it is horizontal, then it would be cerebellar ataxia. Vertical nystagmus is never ever normal in most of the 95% cases. It would be due to posterior fossa tumor or posterior fossa bleed or degeneration. Observe abnormal movements of the trunk or limb. If movement confined to limb, it would be chorea. If confined to trunk, it would be due to ataxia. To confirm this, you must say patient, can you stand without support? Which is very difficult for patient to do this. Please don't talk here to patient for dysarthria. It will give clear cut doubt to examiner that doctor have seen patient earlier. So be smart and give command of gait. It would be broad based gait. Now ask for tandem walk or heel toe walking on straight line and take a turn quickly back. It would be difficult for patient of acute cerebellar ataxia as well as case of Friedreich ataxia to walk on straight line, and when patient tried to turn back he would lose balance. The meanwhile look for foot drop. Your arm should be around the patient during walking and patient can fall down, and this would give a good impression to examiner too. In same standing position, check Romberg. It would be positive in case of Friedreich ataxia. Check back quickly for kyphosis. This is also for the Friedreich ataxia. Now make the patient sit and ask for kalma to check dysarthria, which would be present in case of acute cerebellar ataxia, and explosive speech in case of Friedreich ataxia. Take a pen to one side and hold for few seconds to check for nystagmus in case of cerebellar ataxia. Now do cerebellar ataxia maneuver first on upper limb and then on the lower limb. Say patient to extend your arm straight forward. Place a piece of paper to check for tremors. Do finger nose test for pause pointing. Do dysdiadokinesia maneuver, rapid pronation, supination of the hand on the other hand. Draw a circle in air which is defective in case of cerebellar ataxia. Patient is in sitting position. Check for pendular knee jerk, hammer toe and pes cavus. Same time, do pulse and blood pressure if you found vertical nystagmus. Now examine face, bulbar conjunctiva, nasal bridge, ear bulb for telangiectasia. Ear examination with torch for otitis media, skin for rash or scabs for varicella. Now ask patient to lie down straight, do heel shin test, draw a circle with foot in air which is defective. Do low limb motor examination, check for tone which would be decreased, power would be normal, reflexes would be normal, and Babinski will be normal. Do cardiac examination for cardiomegaly and displace heartbeat, then cover the patient and say thanks to the patient. Now give brief description like 6-year-old child quite cooperative during my examination, having respiratory rate of 20 and pulse rate of 110 per minute with cannula on the right hand. Patient having ataxic gait with truncal ataxia, having obvious nystagmus and dysarthric speech. Cerebellar signs are positive in the form of intentional tremor, past pointing, dysdiadokinesia, pendular knee jerk, and poor heel shin coordination. On motor examination, hypotonia in the lower limb was observed. Rest of the examination is normal in the form of rhombic sign, pes cavus, telangiectasia, a rash over skin. On the basis of my examination, my differential are cerebellar ataxia, paralytic ataxia, and space occupying lesion. Sir, ataxia is purely clinical diagnosis. There is no need to do any other test. On further acquiring, you can say to rule out the cause of acute cerebellar ataxia, I will do some specific investigation according to finding. Just give the name of investigation like drug levels, caloric testing, pus culture and complete blood picture, MRI, somatosensory evoke potential studies, immunoglobulin level, and chromosomal studies. Now, on further querying, you can say drug level for toxicology, caloric test for labyrinthitis, pus culture for otitis media, MRI for space occupying lesion and cerebellar abscess, somatosensory evoke potential studies for paralytic ataxia, immunoglobulin levels, and chromosomal breakage study for ataxia telangiectasia.